Hi, and welcome to our new episode of Digital Health Inside Out. Today, we're going to talk about value-based care. But before that, I want to say that according to the analytics, 85% of people who are our viewers and watch our episodes at least for 5 minutes still have not subscribed to our channel. This is my judging face. Please subscribe as soon as possible, right? Ideally right now. And yeah, we would really appreciate that. So I think a lot of us gonna agree that a lot of things in the US healthcare system are broken. And many people think that value-based care is the answer to fix the system. So today we're going to try to answer the question is about value-based care. Is it a sluggish adoption or an unrealistic utopia? And we have an amazing lineup of experts today. My co-host Sergey Polevikov. Also, we have Sally Lewis. Then Arvind Kavle. And last but not least, Mendel Erlenwine. Hi, Mendel.
You don't have a system that's set up for these companies to succeed.
Did VC Bros destroy digital health?
Healthcare is like 20 years behind.
That's so disrespectful.
Any little error could be catastrophic in medicine. Agents is like the story of 2025.
Digital health.
Let's start with our short intros. I'll go first. I'm Alex. I'm in health tech. I've been building all kind of solutions, tech solutions for healthcare industry. And I'm also a co-founder of a medical device startup called YOD, Your Online Doctor Diagnostics. Sergey, please go next.
Thank you. Great to be here again. Sergey Polevikov. My background is in math, statistics, machine learning. I got into healthcare about 5 years ago to try to fix so many problems we have here, especially in this country. Started my startup in AI health called Well AI, and also have a consultant company in the same area. And I also run, I think, pretty popular Substack called AI Health Uncut. Thank you.
Thank you. Sally.
Hi, everyone. I was a general practitioner in the UK for 24 years, and I'm now Professor of Value in Health Management at Swansea University and an international independent healthcare consultant specializing in healthcare transformation, digital health transformation, and value-based principles as part of that.
Arvind.
Arvind Kavle. I'm a clinical endocrinologist, clinical researcher. I've been in practice in southeastern Pennsylvania since 1999, and value-based care is very near and dear to me since I've been delivering that kind of care for 26 years. And so I'm happy to join the discussion, and thanks for the invitation.
Awesome. And Mendel, please tell us about yourself.
Good to see everyone today. These wonderful legends and stars. My name is Mendel. I am the CEO and founder at CareCo, which is a AI co-pilot for care coordinators. And I'm a big fan of this thing called value-based care. And looking forward to discussing it more today.
Amazing. Actually, let's start with you, Mendel. Tell us what value-based care is. How would you define it in this current US healthcare landscape?
So there's obviously a million ways that you can define it. I look at value-based care in its most simplistic way as aligning financial incentives with patient outcomes. To me, that's pretty much the one line that sums it up. There's a story that I like to say because this is when it really clicked for me, and I've said this many times on different podcasts, but a couple years ago, I was at an office building and I saw this water cooler sitting in the break room, and on the water cooler was a handwritten note. And the note was from the company that owned the water cooler. And it was describing a technician that had come out. It was a note from a technician that had come out the day before to service the water cooler. And it described all the different things that that the technician did, cleaned the inside filters, the outside filters, wiped down the machine, did a whole bunch of stuff. And I sat there making my coffee, and it struck me, this is fascinating. You know, this office was in Brooklyn, where if you've never tried getting around Brooklyn, it's impossible. So 1 mile in Brooklyn can take you 45 minutes. And so I'm like, this is so interesting. This for-profit company that owns these water coolers somehow determined that it was worthwhile for them to send out a technician to service this water cooler. But what was the weirdest part to me is I knew that no one had complained about the water cooler. It was a fully preventive checkup on this water cooler. No one complained that it was broken. And so why would a for-profit company waste their resources by sending somebody out to go check a water cooler that didn't have any problems? And that's when it kind of clicked with me that, well, the obvious reason is because they've determined that that is the better way to make money, that they will be more profitable, whether it's because they'll have happier customers or because of the longevity of the water cooler, or for all the reasons. They will make more money as a for-profit company by sending somebody out preventively, proactively to go take care of their equipment without anybody having to complain. And to me, that's a really, really good synopsis of why value-based care, just from first principles, makes sense. When you align financial incentives with the outcome, you allow folks to start thinking differently in the way that they care for patients.
Great example, and we're going to talk about incentives a lot today. Does anyone have any other opinions about value-based care or any other examples, how we can explain to our audience? Yes, Sally, please.
So I would agree with Mendel that it is about aligning outcomes and costs, and about how we make sure that we get the most out of the resources that we put into healthcare. It's not just the US healthcare system that's broken, by the way. It's every healthcare system in the world. It just manifests itself in a different way depending on where you are. So I'm in the UK, so it looks a little bit different, but it's also a little bit broken here as well, as I'm sure you'll have heard. Keeping a focus on outcomes that matter to patients is really, really important. And thinking about how we use resources is also important. So incentives are a part of that, but I would expand on what Mendel has just said to say it's about thinking very carefully about how we use the resources, not just about incentivizing and thinking about profit, but it is about how we use finance to nudge behavior in the right way in healthcare. And there are a number of different ways to do that. And I think the other really critical thing about value-based healthcare, wherever you are in the world, is to think about it as a whole pathway of care, a whole system. So true value comes when we think about a whole pathway from prevention through early diagnosis, optimizing intervention and follow-up care, and on into really good palliative care if that's part of it. Because that helps us understand how we deploy our workforce, how we use digital technologies to support those pathways of care, and how we deliver value to patients and the system across that whole pathway. A hospital or an individual can't do the whole thing on their own. They're part of it. So outcomes, costs, and financial levers, and whole pathways.
So I might like to add a couple of things to what Sally and Mendel said. And by the way, I agree with Mendel 100% in the philosophy that he's espousing. The only problem is that the example he describes does not apply to US healthcare, unfortunately. And the reason that worked beautifully in a water cooler is because there was a buyer and a seller, and the user was a buyer. Okay. And in healthcare, there are multiple middle parties, not just a third party. There's a third and a fourth and a fifth party. And the financial incentives are divided amongst the parties. And so the deliverer of care has a very little incentive to optimize care, whereas the receiver of care has very little incentive to optimize his or her own care or her own self-care. And all the other parties in the middle have a very high incentive to actually keep costs high and incentives low. And that's because that's just how, so to start off the discussion, you mentioned that the system was broken, Alex. Actually, the system is not broken at all. The system is working exactly how it was designed and how it has been modified over the years. This was actually what we are seeing right now is actually a predicted culmination and I've been at this for 30 plus years, and at every stage, except in my first few years of practice, I've been involved in policy making and sort of taking positions on policies ever since about 2003, 2004. So I'm talking 22 years here. And sort of, I sound like a broken record because almost all the things that I predicted have come true. And so sort of the idea that Mendel described is actually a perfect idea, is to align financial incentives with outcomes. But the problem is there are too many hands in this pot, and we really need to remove those hands in order for that to actually take effect. And we can talk more as we go along.
This is actually perfect to my next question, because I wanted to go through each part of the equation and actually figure out what are the incentives. And I think all of us agree that value-based care is based on patients and patient-centric. So let's actually start with patients. Do you think patients, first of all, they know about the concept of value-based care, they understand it, and we're talking about the United States. And second question, are they incentivized to switch from value-based care to value-based care from fee-for-service model?
We are all patients ultimately, right? Each of us is a patient. That's how I look at the whole healthcare scheme. We are all patients, and if we don't address it from a patient standpoint, we are missing the whole point, right? So the reason patients are afraid and actually not very incentivized is because of financial weakness. They are not financially strong. Because if you are an employee of an organization and your employer purchases quote unquote insurance or benefits plan for you, you are contributing through your paycheck a percentage of the premium towards the insurance plan. And the employer is contributing a percentage. And this may be a 30-70 or a 40-60 or even a 50-50 contribution, which means in your mind, you have already contributed towards paying for the structure to be in place. And on top of that, most of the plans have high deductibles, the lowest deductible being about $1,800. That means the first $1,800 comes out of your pocket after you've contributed maybe $200 or $300 a month towards the premium. So the financial incentive is very low on the patient's part. Now, if you're asking them to join a direct primary care practice for $50 a month or $80 a month, and that does not apply towards their deductible, then you're adding more to their out-of-pocket post-tax cost. So nobody has the appetite to do that, right? So if you're asking people to do that kind of stuff, then there has to be a different financial structure. So essentially, like every other interaction, the entity that controls the dollar controls the process. And unless we change that, patients are not going to be empowered to do anything other than what's happening.
And just to add a little bit, 75% of patients in the US are on their employer's insurance plans. So why the hell would they switch? I mean, I think a lot of pressure here in the US is on employers, on things like, self-insured plans and direct contracting, which in my opinion has a lot of relevance to value-based care. But again, I think there are a lot of risks and a lot of uncertainty, and that's the reason employers are not doing it. So there's a link to employers here that we have to consider.
Yeah, I don't know if we're just going around, but the only thing I would add, Arvind, some really, really great points. Love what you said earlier about the difference between the water cooler, and I have a lot to say on that as well. And obviously spot on. And between what you and Sergey just said, I think you've explained the mechanics of possibly why it's not ready for patients yet to a large extent. But I think the larger issue, you said we are all patients, right? Which is 100% true. But unfortunately, not all patients are us. Meaning, not all patients are spending their days, talking about these topics. In fact, as someone that, obviously speaks to a lot of physicians, and even I've done quite a few hours on the streets in DC and different big cities just talking to humans on the street about healthcare. I would say that 9.7 out of 10 patients don't even know what value-based care is, nor like, why would they? Why should they? They have no idea what that even means. If you went up to a patient, you said, hey, would you like to switch from fee-for-service to value-based care? They would just say, dude, I'm trying to get lunch. I don't know what you're talking about. And so I think that patients don't know anything about for the most part, obviously, don't know anything about the inner mechanics or the mechanisms of the financial incentives and the way that it works. All people know is the experience that they get. And the experience is abysmal, obviously. It's expensive. It's convoluted. Getting insurance, unless you're unless you're on an employer plan, getting insurance is extremely difficult, complicated, convoluted. And then the actual experience is obviously extremely expensive and cumbersome with quite limited options. So I propose obviously a larger issue. And I actually think that it's conversations like these, exactly like this. And so obviously kudos to our host today, that help to create a little bit more content around the conversation, and hopefully can reach some patients, not just some doctors, to even say, hey, I've never really thought about this. I'm paying into something. I don't even know how that works. Where do my dollars go? Who processes it? How does it get paid? Who's invoicing? So that's my little take on the patients part of it.
Am I allowed to be provocative? Good. Because I sort of feel like I'm on a slightly different bus here. It's interesting to me that you've jumped straight to payment mechanisms as equating with value-based healthcare. And for us in Europe, and actually this is true in Australia and the Middle East too, this is not how we think about value-based healthcare at all. We think about value-based healthcare as a fundamental remodeling of the processes and services within healthcare systems towards better outcomes for patients and more sustainable healthcare systems, not as a fix for, frankly, a very high cost and slightly broken US insurance-based system. There are other insurance-based systems in the world that are less costly. The sky doesn't fall in as a provider if you drop, an American-style system. I know this because I was running my own practice for many, many years. So I would suggest the place to start is not the payment mechanisms. It's what is the sort of healthcare system that you would like to see in the US? And then how do we create that? And I do agree that you'll need different structures to do that, because the out-of-pocket payments for patients is really quite eye-watering. You're paying too much for your drugs as a system. There's so many things that need to be fixed. But a focus on value in the system could help you to do that. But saying, oh, well, we can't do it because the system is broken is precisely the point, I think. So I think it would be nice to get back to first principles of what value in a system actually means.
I love all the points. And I'll talk from the patient perspective right now. So a few months ago, I did my yearly physical exam and went to see my PCP. We talked about my health. Then she referred me to do some blood work, and then I left home. And a week later, somebody from the clinic called me, and they're like, immediately, please come see PCP. I'm like, what's happening? Do I need to finish my will, or like, how bad is it? Can you like call my PCP? Like, what's going on? And they're like, no, you have to come and you'll see your doctor, primary care physician in person. She'll tell you everything. I'm like, okay, I'll have to switch everything in my schedule, go to the clinic, probably spend some time in traffic, and then I'll figure out what's happening. So when I got there, what basically she told me is that my cholesterol is a little bit high. I'm
Seriously?
like, yeah, I'm like, why couldn't we do telehealth? You have telehealth as one of the services. Why couldn't we do telehealth? And so I could save tons of time. And they're like, well, yeah, this is our protocol. You have to see me so I can tell you this. And then she referred me to do more blood work. She did a referral to a nutritionist and some other exams. And I don't have any doubts that my doctor wants me to stay healthy and be healthy. But I think the system forced her to, first of all, bring me to the clinic, because the clinic is going to get more money for my in-person visit than telehealth. and then sell me more services. And I already know what nutrition would tell me. I think my PCP would tell me the same thing. I don't need to see that. So me as a patient, I want to stay out of the hospital as much as possible. And that's not an incentive of a health system, because in the fee-for-service model, they want me to come to the hospital as much as possible. So that's my patient take. Let's talk about health systems since we started about it. Arvind, what do you think? What should I do in my situation, and if value-based care can help me?
So, like Sally said, the value should come for the patient, and not to flag my own practice, but we have a lot, thousands of patients who see value in what we provide, and most of the work we do is considered in the quote unquote fee for service model. And I'll give you one example of a patient. This is an extreme example, but it's an example that represents what value means to patients. So I had a patient who just retired. This was the first year of COVID. And the summer of 2020, she retired, and she remarried, and she was going to relocate to Florida. And just before she relocated, December of 2020, she was diagnosed with acute leukemia. But she decided to move anyway. Till that time, she's a patient with type 2 diabetes on insulin. We have her on an insulin pump, which is an automated insulin delivery device. Sergey will be aware of that. So what happened was, when she moved down there, she signed up with the cancer center in Tampa, Florida, started chemotherapy, and essentially, they basically, eradicated the existing bone marrow and replaced it with new bone marrow. So she has to stay in isolation after bone marrow transplantation. So this is, I'm speeding up the history. So I just want to give you the gist of the point is that throughout her chemotherapy, her isolation, and then she developed graft versus host reaction to the bone marrow. So she ended up with high dose pulse steroids. Then she came home, and then she fractured a vertebra in her back. So she ended up with kyphoplasty. And then 6 months later, she ended up with 4-vessel heart bypass, and so on and so forth, over a period of 12 to 13 months. And we maintained her glucose control in perfect condition from out of state in Pennsylvania to Florida, right? Yeah. And nothing, and she made it a rule in every hospital that she went to that nobody's touching her insulin pump. We're going to manage it remotely. And two things happened there. One is that we actually got paid for everything that we did, and we didn't interrupt any of her treatments, right? And the only difference that then was we were under the COVID emergency, so we were able to get flexibility in billing requirements, right? So they weren't fixing our payments to doing certain things a certain way. And until today, she is still my patient. She flies in once a year to see me just to make sure that she remains a part of my practice. Again, that doesn't have to happen, but it has to happen because of state licensing requirements. So technically, I cannot see a patient who's now officially a Florida resident, but I can still see her if she comes in physically to see me once a year at least. So you see how the structure has been built to serve inefficiency, not efficiency, right? But if, like what Mendel said, if we align the payment to what is actually in the best interest of the patients, it doesn't really matter what you call it, whether it's fee for service or bundle payment or whatever else. There is value in it for the patient. And that's what we have to emphasize is the patient must decide and derive value if it has to be a real value-based care. Right? So I have dozens of stories like this, but she's one of the most extreme cases. She eventually made her husband become my patient as well, even though after all these things. And she forced me to get a Florida license eventually. So I got my Florida license now, so I can technically see her without getting penalized. But nevertheless, the system is set up that way, right? So that's the problem. And so it doesn't matter whether it's fee for service or otherwise, there are so many barriers to care that efficiency, technology healthcare is the only industry where technology makes things more difficult and more expensive. Everywhere else is exactly the opposite, right? And that's the problem.
Yeah, that's a great story. We should on this podcast, we should officially rename it from value-based care to value to patient care. And that's going to be the new movement. Very powerful talk. Thanks for sharing that.
Exactly what value-based healthcare is. And if you apply those principles wherever you are in the world, you can figure out then ways to overcome the barriers to the extent that you can. You can't solve everything, and there are certain structures you can't change, I mean, I work in a system. I've worked in a system as you would say, family physician in the US, as an assistant medical director in an ACO type organization, as a policy advisor, as an academic. I've been around the bazaars, and our problem in Wales and in the UK in general is that we don't really have any incentives, or we don't have many incentives. Care is free for patients at the point of delivery, and everything is free. And physicians are reimbursed very differently. Now, on the one hand, that's great because we don't have a lot of the bureaucracy and the difficulty around prior approvals, I think you call it, and various hurdles like that. But in a system where you don't have any incentives at all, it's very difficult to nudge behavior and create the right sort of behaviors, whether that's towards efficiency and better processes, or indeed buying technology, which has been a nightmare for me personally, procuring new technology and getting the funds to do that, or shifting resources to what really matters to patients. So your story really resonates, Arvind, because that's exactly the sort of individual tweaks to a patient's care to make it work for them, in alignment with lots of other complicated things that are going on in their life. That's what value-based healthcare is. And it's really, I think you said earlier, Alex, it's not for us. We're individuals on this podcast who have agency and can navigate the system and get what we need / want. Most people are not like that. And the system should work to support those people and make sure that they get the best outcomes that they deserve.
I think I'm still a little bit confused on the provider side. And Arvind, I love your example, but going back to my example, both clinic for my clinic and you as a healthcare provider, completely different incentives in that way. Like my clinic wants me to sell more services. And in your case, theoretically, you could also, if we're still operating in the fee-for-service model, theoretically, you can still sell more services to these patients from Florida if you want to make more money on it. So not every health system or healthcare provider would behave the same way as you do. And I'm pretty sure that actually most of them are thinking, first of all, of the profits. So my understanding is that healthcare systems are not incentivized at all. And most of them are not incentivized to switch to value-based care model. Would you agree with that?
So there's a little bit of ignorance of facts in the system, amongst the clinician community, only because over the last 5 years, and I know this because I hate to bring extreme examples, but I without extreme examples, it's difficult for me to support what I'm saying. So everyone has heard of the Freestyle Libre continuous glucose monitors and the Dexcom glucose monitors. So these are all continuous monitors that you apply on the skin, and they measure your glucose continuously throughout the day and night, and for anywhere from 10 to 15 days. And these can be linked to your cell phone, which can then connect to our office, and we can remotely monitor your glucose at any time, wherever you are in the world. Okay, and this has been available for at least, I would say, for commercial use about close to 10 years now, about 9 years, I think. Before which we used to only use it for people with type 1 diabetes. And the story goes this way, the example I'm giving you will help you understand why people in the clinical world do not optimize the use of technology and still get paid. It's just because of their ignorance. So in 2015, 2016, the first generation of baby boomers was entering Medicare. They were turning 65. And we had a set of about a half a dozen or to a dozen of these people who had type 1 diabetes. That means they had juvenile diabetes for 35, 40, 50 years, maybe some even longer. And most of them had been on continuous glucose monitors and insulin pumps, so what we call as automated insulin delivery devices. And one such person entered Medicare in 2016 and had been on this pump and sensor device for about 10 years. And all of a sudden, Medicare basically dropped him and essentially said, we don't have a policy to cover for your continuous glucose monitors. They just didn't have a policy. So he didn't so as a certain month, he was basically off of everything. He didn't know what to do. So we had to scramble to get him some supplies. And then we actually sued Medicare. And I was a solo practitioner at that time. And so it's me and my nurse. And so we are taking on Medicare. We actually went to court and hired an advocate for the patient, collected documents, and we sued. And we won. And we won in late 2016. And Medicare said, okay, we don't have a policy, but we'll cover for 6 months. So we got it for 6 months. And then 2017 came along and we're back to square one. And we have no coverage, right? And so we sued again. And by this time, there were about 8 or 9 other endocrinologists across the country who were facing the same issue. And they were all suing in their own local district courts. And we all won our cases in 2017 again. And by the time we'd set a precedent, Medicare was forced to come up with a policy to cover for continuous glucose monitors. So at that time, they were covering it only for type 1 patients. Eventually, we convinced them to cover it for anybody who is on insulin. And then finally, they're now covering for anybody that has diabetes and is on insulin, not on insulin, or having demonstrated hypoglycemia. So the moral of this story is that if we do the right thing, there's actually a payment method that will accompany that. And so what has happened? So the two things have happened due directly to that. And of course, the COVID pandemic, I kind of like to see good things out of bad here. The COVID pandemic actually helped because it really opened up the channels of regulatory relaxation, where people could actually do what they thought was the right thing to do and expect payment for it, right? And the patients also understood, right, that they can actually access their doctors without leaving their houses. And that changed. So the two things happening in our practice was we were able to reduce our, what we call as a time to target A1C. A1C is a test that we measure for diabetes control. And for people who are coming in with an average A1C of 11 change, which means your average sugar is close to 300, and reducing that average glucose to about 150 to 160, which means an A1C of about 7.3, used to take us more than a year to do. And that was actually good compared to the rest of the country. That was in 2018 and 19. Once COVID hit and we were able to use all the flexibilities afforded by Medicare, since 2020 till 2024, all 4 years, we've reduced that 12-month time to 6 months or less. Okay? And what does that imply? That implies a tremendous cost savings for Medicare. In fact, we were able to demonstrate in 2022 that for patients attributed to us for diabetes care, compared to all other clinicians, we saved Medicare about $6,800 per member. And we had 321 members attributed. So we saved Medicare about $14 million just for 2022. Right? So, and not only that, so we were able to show clinical improvement as well as cost reduction. Right? So, and at the same time, when we did our analytics from our revenues kept going up about 5 to 6% every year, despite Medicare cutting our payments every year. So what I'm trying to say is your doctor doesn't understand the method of using technology to benefit the patient as well as benefit their practice at the same time. It's just a lack of knowledge that is keeping people back. And it's the same thing with technology companies. Right? So Abbott makes or used to make another sensor called an office-based probe sensor, which means we would actually put these sensors. It's a blinded study. Patients would not know anything about it. You just let them go, keep some food records, come back in 14 days, and then we would remove the data, collect the data, talk to the patient, understand the data with the patient in front of the computers. All of a sudden, they stopped producing it, probably because they weren't selling enough of it. And when we asked them, they said there's no role for these kind of studies. So it just goes to show that the ignorance, the depth of ignorance, is everywhere. Clinicians don't understand it. The technology companies don't understand it. Insurance companies don't understand it. Medicare or government agencies don't understand it. It's just a lot of ignorance. People think it's one way or the other. It doesn't have to be that way.
It's a really cool segment. I mean, what I heard from you, Doc, is that value-based care and patient-based care makes sense, full stop, period. And if you choose to operate in that fashion, the rules will, and payment incentives, et cetera, will kind of find themselves around you. And the reason why I think you, and first of all, that, you taking Medicare to court and winning, that's one of the most astounding stories I've heard in a while. Just the most astounding part is that you did it, not that you won. So that's like incredible. But the reason why it actually makes sense is because at the top, at the payer level, of course, value-based care makes sense. Of course, they don't want to pay. They want to pay less money. So if you can show them, hey, if you pay $20 for this, slap it on the patient, and then you're going to save $1,000 from those ER visits, then very possibly you will be able to create change. And the fact that you did that at your level as a single practitioner is pretty astounding. I have to kind of digest that a little bit more, but I think it sounds like you're talking to the doctors and saying, listen, this thing makes sense. Going back to what I said at the beginning, first principles, go back to it. It makes sense. Take care of the patient. Try to keep the patient out of the hospital. Don't do silliness like what Alex was describing earlier, where like you're schlepping the patient 4 hours into your office just to be able to put a blood pressure cuff on them in person so you can bill this. Like, don't do that. And the rest will kind of flow around it. I think that's a beautiful message. I really appreciate that.
I would echo that. I mean, that's exactly been my experience, Arvind. That's a lovely story. I haven't been so brave as to take anyone to court over this, but this notion that there's a grassroots movement of clinicians that are doing this work is absolutely right, and that's true in other countries as well. It's true in the UK, it's true in Europe, and does start to force change. On the payer side, I absolutely agree with that, because this is just like anything else. It's a massive change management piece, isn't it? And there's always resistance to change in change management, and you always need your early adopters. But bravo for taking Medicare to court. That's extreme.
I had some allies in that, so it was good. It's good to win, Always good to win, for the right reasons, of course.
So on the provider side, I mean, on the patient side, I agree. I mean, it's a beautiful thing. We all want that. I think, again, for providers, they need to think also how they're gonna make their ends meet. I don't know. I believe that value-based care would only work financially when we have scale. Right now, we don't have scale. So, for example, I'm a very big fan of independent physicians. I've got to know a lot of them. I don't know a single independent physician who kind of doesn't care about their patient and kind of all in on this fee-for-service. A lot of them want to switch from fee-for-service and basically drop payers and say, you know what, we're just going to do, for example, direct primary care. It's a risk for them because they know they're going to lose patients. Again, coming back to scale, because patients, they're going to see you switch and they're like, well, we're just going to find another provider because my employer is paying my insurance. Why would I stay? Why would I switch, right? And so, but a lot of them are facing that reality right now because their reimbursement rates are not paying for a lot of their bills. They're cutting costs. Their cutting costs are not actually at the same speed as their reimbursement rate is being cut. So they're facing a dilemma. Am I selling my practice to somebody like Optum or a private equity? And obviously we know what's going to happen with Optum. You know, they're not fans of value-based care. Or I'm switching to value-based care, but I don't know if I'm going to make it financially because I'm going to lose patients for sure. There's no other way. So I'm going to reduce my revenue and I need to cut my costs. Costs are going to be cut because it's not going to be as much billing. But again, it's a lot of thinking. And I think that's where we are with a lot of these physicians' offices. And so it's not an easy answer, the bottom line.
But can someone explain to me, with like when we're talking about health systems, the incentive is fairly straightforward. You provide a service, you charge insurance company, and you get paid. If we're talking about value-based care in the classic approach, how would we measure the outcomes, and what are the main criteria for health system to measure outcomes to get paid for keeping a patient healthy and out of hospital? What are the measurements?
Actually, Sally wrote a lot about that.
Just to preface what you're saying, Sally, I didn't mean to interrupt you. Just want to say, so health systems own hospitals. So they would not do anything to cut their own legs, right? So they don't want to do anything that would reduce their hospital admission rate. So you're asking the wrong question, right? So if I'm running a hospital, I want my beds to be occupied. I don't want empty beds because I still have to staff my wards, my critical care step-down units. I'm not going to save money by not hiring nurses or aides. So I'd rather have the beds full, right? So the incentive is not there to not have the beds full. So somebody actually wrote saying that, the most dangerous thing to a person in the community is an empty hospital bed, right? So and that's very true. And so I'm not tagging a hospital administrator. That's just their job, right? Their job is to have the hospital full or as full as possible. So that's just wanted to keep that in mind as we go.
And that's true in the US, isn't it, Arvind? But almost nowhere else. It's very, very, yeah, it depends how the healthcare system is set up. I've spent most of my working life trying to get patients out of hospital as quickly as possible because we're trying to save beds. Yeah, so it's an interesting tension there. But I think there are some commonalities across all healthcare systems. Coming back to the outcomes piece to answer the question. Let's say we live in an ideal world. In an ideal world, we want to know how patients are doing, right? We want to know what their clinical outcomes are, and ideally, so the clinical outcomes, I'll define that for you. It could be, whether a tumor has gone, or it could be, the diabetes management that Arvind was talking about earlier is absolutely perfect and on point. Those are clinical outcomes. And then ideally, we want to know patient outcomes as well, which is a lot more about the symptom burden that patients have from their illness, or it might be about global quality of life as well. And these things are also important measures, as are the sort of administrative data that we see from hospitals, whether, putting aside how people like to use that data, but admission rates and readmission rates and that kind of thing. So if you take heart failure, for example, very, very common debilitating condition, we would want to know the stage of a patient's heart failure. We would want to know their symptom burden. How breathless are they? How fatigued are they? This kind of thing. And a really important indicator of how well somebody is managing their heart failure is perhaps their 30-day readmission rate, isn't it, with their heart failure. So how quickly they end up back in the ED, having had a hospital admission. So those are the sorts of data we would want to track. Whether you call it value-based healthcare or whether you just call it common sense, I would say, this is the sort of data you want to know if you care about your patient. And then it's how you use it from there on in. It's what you do with it that generates the value for patients and the system alike. But I'm an advocate for measuring this data and for making it very, very transparent. Now, that data can be used multiple ways. You can use, as we've heard really eloquently from Arvind, you can use that data in direct care of a patient to guide how you're managing them with them as a partner in that care. Like your patient that moved to Florida, Arvind. You can use it to inform whether your services are actually delivering the benefit that you would expect them to, and whether there's any improvement that you need to make to those services. You can use them to compare with other institutions, but that's a whole other level above. But I'm arguing that we should be transparent, and if we're not transparent, we're failing our patients. Whether, and people don't like that, but it is true. We're failing our patients, and it's not necessarily about saying Arvind's good and I'm a bad doctor. It's about trying to understand what is going on with our patients and how we can meet their needs. And in terms of what's in it for the provider, Sergey, to your point earlier, how you will use that data in the context of a private healthcare system compared to a public healthcare system will be nuanced. It will be different because context is everything when you're applying the value-based healthcare methodology. And that's kind of what I think you were saying earlier, Arvind, which was like you build the thing around what the right thing to do is. And I think that if I was going to have one takeaway point from this podcast, it would be that, because that is true in America, that is true in Europe, and it's true in the Middle East, and it's true in a public healthcare system, and it's true in a private healthcare system where you want loads of people in your beds and to be seen as the best on Newsweek and all of that jazz.
And I think I've seen in your work, Sal, or maybe it was somebody else, that could be quite challenging how to even measure success of value-based care. The outcome. It could be gamed. If it's one particular measure, then you concentrate on this one and kind of disregard everything else. If you have multimorbid patient, it's not just one disease, it's a whole bunch of factors, including social factors. It's challenging. And I've also seen a recent study of Medicare's value-based program, FBP, and apparently it's the cost has been higher than benefits, at least according to this one study. So it's not easy. It's not easy, especially financially.
Really, really difficult, actually. And I mean, even capturing outcomes properly, especially patient-reported outcomes as part of care, is extremely hard. And you can't do it as a data collection exercise for a payment mechanism. I can tell you that now, because the patients will go, you've got to embed it. It's got to be meaningful. It's got to be a tool of care first, in the way that Arvind has described, before you start thinking about any secondary uses of the data. And if the structures are fundamentally broken, you can't say you're doing value-based healthcare, and so of course studies are going to fail. There are many other examples of where there's, really great value being added for patients and systems. So it's about context as well, in my view, and being realistic about what you're trying to achieve, and not selling value-based healthcare as a panacea that's going to fix something. It's not. It's a set of tools which are going to help us. And keeping aside to the fact that we need to understand patient outcomes is our duty in my view, because the sole purpose of healthcare should not be to generate a profit. I accept that is the reality in many systems, but if that's the only reality, then we're really on a slippery slope to a very dark place.
Mendel, you are usually very optimistic about VBC, and you've interviewed a bunch of folks in this space. Who do you think are the role models, the success stories of companies that consider themselves value-based care companies in the US? would you say there are some winners in that space?
And then I'll tell you who are not.
Those are easier, unfortunately. I like Oak Street. I know they sold to CVS, but I think Oak Street was a great and is still a great company. I'm sure there's been some culture shift and things have changed since, but I think that the model that took them from zero until sale, I'm not going to speak for after, was very positive. I actually went down there. It's your neck of the woods, Alex, in Chicago. I was down there and had Dr. Ali Khan on the podcast, and it was such a good podcast that the week later he says, long story short, I got a letter from legal that the podcast is going to go out. So it was a phenomenal podcast. Very transparent. But what I learned, so I can't share all the details, but what I learned is that taking the concept that Arvind said earlier, which is care for the patients, do the right thing by the patients. And they kind of took that and built a system around it. And they took that just all the way to the way that they deal with transportation and the way that they communicate with their patients. And, the fact that that every single person that works at Oak Street, whether it's the physicians or the janitor, so to speak, and every single person in between is out with a mission to help the patients and then communicates upwards. It's a fascinating culture. I think they were really onto something. I mean, obviously you've got ChenMed does a great job as well. They've also gone through quite a bit of shake up, and I had the opportunity of hanging out a bunch with Dr. Gordon Chen, and also went down there in Florida and got to tour that operation. So I think there are some pretty good examples. And what's always surprising to me is when you look at the successful ones, it doesn't actually seem like rocket science. It's like, just focus on prevention, focus on communication, focus on care coordination, focus on engagement, try to focus on like, hey, is this patient happy? Are they getting what they need? Instead of like all the jammering on about different models and every time I look at a successful one, that's really what stands out to me, is that when you just ask them like, oh, what is it? It's kind of simple, and I see Sally heavily agreeing with that, but yeah, I think often it's overcomplicated, but I do think that it's inherently overcomplicated from when you're working from within the confines of the existing kind of web. And I think that all these small successes, they kind of found a way to take like a small vertical and build it up and become successful, but kind of from a little bit outside the box, and that I think makes it a little clearer. It's always easier to write on a new chalkboard than it is to erase the chalkboard that's been written on for 100 years and then try to draw something that's somewhat legible. So yeah, those would be the ones that come to the top of mind. Probably Oak Street and ChenMed. Obviously there's quite a few others, but yeah.
And I agree. When I was trying to answer the same question, trying to do my research, I've checked, I've Googled a lot, and yeah, those were on the list, obviously. But then I started to get deeper, and it's funny that you brought up ChenMed. I went to check the reviews on Reddit, and looks like they have really big problems with clinicians because the turnout is huge. And one of the reviews, they say that the type of patients you see depend on the location. South Florida clinics have healthier clients compared to poor rural areas, but the goals are the same everywhere. Bonuses are hard to obtain. You have to hit multiple targets, and the most challenging one is hospital admissions. Even if the hospitalization is preventable or planned surgery, it counts against you. So again, I don't know much about, like, I didn't speak to any former or current employees, but looks like there are a lot of other problems on that side as well. So I'm really, to be honest, I'm struggling to find like a best example that like works perfectly, and multiple reasons we discussed previously on this pod actually explain why everyone is struggling in this space. That's my take.
And I'll hop over to Robert in a sec, but just to answer that, and I mean, obviously there could be positive reviews, negative reviews. I do agree. I think that the larger, and this is just a thought that popped in my head, but I think that the larger the example becomes, the lesser chance it has at success. I think the biggest successes with value-based care maybe is like the simpler, the smaller. Like just think of the primary care doc that's doing a concierge model. All his patients love him and he manages them and he gets paid. He makes $200,000, $300,000, $400,000, $500,000 a year. He's rocking and rolling. He goes on vacation once or twice a year. He does what he loves doing and he cares about his patients, and he's not going to tell a patient to go to the ER just to save himself. But he's also going to be there for them. Like when you kind of boil it down to very, very specific examples where value-based care seems to work, I think as you try to include the whole web of the national healthcare system into value-based care and you try kind of shoehorning it, that's when it becomes really difficult because of all the examples that you said earlier. Like if the hospital is the loss leader, then you can't have a system that's then owned by the system that's then fighting against the incentive structure of the system. So like that's when it starts becoming very overwhelming for me on a personal level. But if you just zoom it back down to like a simple thing, like, hey, there's a doctor, and instead of being paid for his patients to be sick, like he cares about his patients and he wants them to be a good life. And I'm lucky to have a PCP who's a friend of mine, and I know what that feels like. And it's a really, really good feeling where you know that you're going to call him or you could WhatsApp him. Or I was in Vegas at a conference and my kid was like choking up blood, and I was able to have him at the middle of the night go to my house and go figure out what's going on. Like to have that kind of relationship with somebody is so tremendous. And so when you boil it down, it makes a lot of sense. And sorry to cut in, Arvind, over to you.
You said what I was going to say is that when you're looking for success in these sort of semi-large organizations, you're not going to find it because, again, the incentives are very monetary. And for a clinician, the incentive should not be monetary alone. And yes, money matters, but ultimately your professional satisfaction and your sort of sense of achievement to deliver the goods for your patient and be there must be your primary goal. And if that brings you the money, then it's automatic. You don't. But if in a corporate structure, whether it's ChenMed, and I visited ChenMed in Philadelphia, 2018, 2019. Over the years since 2017, I have sort of developed a bundled program for my diabetes management. So I've taken all the parts that myself, my staff, and my diabetes educators do and build an annual program out of it for a fixed cost and with certain fixed outcomes. And we offer it as a 2-year program, 1 year to achieve control, and the next year to reinforce the structure and teach patients self-management. So our motto is, if you use us for 2 years, you won't need us after that. Right? So I offered that to ChenMed at that time, and they were not interested. Right? And because they're like, oh, we can manage our diabetes. So a lot of times what happens is that their incentives, they don't understand what their actual incentives are. And like you said, the hospitalization incentives and stuff. So another story to illustrate, right? So I've been practicing in my area for 26 years. And 5 years ago, I got elected as the chair of medicine at my local hospital. And I was the only independent physician as one of the department chairs at that time. All the others were hospital employed physicians. So when I went for my first, interdepartmental meeting, medical executive committee, nobody knew me because I had not done hospital work for over a decade before that. And the ER doc, the chair of the ER, emergency physician, came to me and he said, "I've never seen a patient of yours in my 12 years in the emergency room." I said, "Yeah, that's the reason why I practice, is because I don't want my patients in an emergency room." Right? So sometimes the success just happens automatically. You don't have to beat the drum of success. People will tell you when you're successful, right? I was on a golf course with another hospital group last year and a half ago, 2 years ago. And so one of my partners was also an emergency room doctor from another hospital. I'm sort of situated in the middle of 3 large hospital chains. And he's like, I've been in the ER for so many years, like in the 8 or 9 years, I've never seen a patient of yours. I said, yeah, I've been in practice since '99. And the reason is, we manage everybody to the best of our ability to keep them out of the ER. Right? So success stories happen automatically. And it's very important that you look for success stories in small areas, like Mendel said, the concierge primary care or the DPC person, or somebody who is really small groups. And the way to expand that is to really connect these small individual independent physician practices by technology, by to say, okay, if my patient goes to Sally's neck of the woods and falls sick, she should be able to access me and say, hey, I have a patient of yours, what do you want me to do for him or her, and that should be the way technology connects us. We don't need large hospitals, corporate systems to do that. We just need technology to connect physician practices. And that's really how you also revitalize independent practice. And we have lost that in the last decade and a half, so to speak, at least in the US, because of the effects of the Affordable Care Act, which really, helped consolidate hospital systems and insurance systems through financial incentives.
Let me push back on Mendel and Arvind on this basic model. I think we all want that. The reason it's not happening, like things like concierge and direct primary care, or at least not at the speed that we would like to. First of all, technology is not there, and I'm looking at AI. It's to make it worthwhile in terms of costs. We're still not there yet, especially for those kind of models. Secondly, if you are, let's say, you just finished medical school residency, you make a decision: are you going to a big organization or hospital, or you start this simple model? I mean, that's a lot of risk for a young person to take. And on the other hand, if you are an established doctor, think about it. You have 10,000 patients. You have very successful clinic, for example. You're gonna lose those patients. You cannot just switch and say, oh, by the way, here's an email, I'm switching to value-based. You're gonna lose like at least half, in my estimation, because they're like, well, we have our employer paying our insurance. Like, how are we gonna pay you for that? So, in both cases, it's a big risk, and that's my opinion. We don't see that happening to the extent that we want to.
So those patients who stay are actually higher value patients for the practice. Many years ago, about 2007, 2008, 2009, I basically canceled all my insurance contracts, kept only one or two. And I lost only about maybe 25% of my patients. And the rest of them became cash-paying patients, which till today, they are still my patients. So the fear
I feel like not everybody's like you. It's like some of these patients you've been building relationships for decades in certain cases, and so I'm just saying it's the right thing to do. It's just a lot of risk that perhaps not many people realize.
Comes back to how you define value, right? So if the patient finds value in you, and your reason, and the funny part was, most of the patients who left me after I quit their insurances were the upper tier, higher earning people. Almost all of my blue collar worker patients, middle tier patients, police officers, teachers, mechanics, waitresses, they all stayed with me paying cash.
Yeah. I've seen kind of similar, I do on the service side of my business, Proviva Healthcare, we do chronic care management programs for a lot of different doctors. And I've seen a bunch of them do, on top of insurance, some instead of insurance, but you actually run the numbers and it's like, you got 250 patients paying you $2,000 a year, you're making 500 grand, it's like, that's doable. And you know what, for your typical person that's paying deductibles and copays all year anyway, is $2,000 over the year that hard to find? You don't have to be the richest person to, so it's quite a fascinating model. And what you find is that once they get rid of the burden of the levels of documentation and just general bureaucracy that they're forced to go through to hopefully not get denied and hopefully get paid just in the nick of time to make payroll, They're able to they get their life back a little bit. I've seen this. I've seen it with doctors. So it definitely, you said, Serge, you said not everyone's like you, Arvin, and that's true. It does take a more entrepreneurially minded person to even have the thought process of stepping a little bit outside of the box. But I think the larger point is that when you decide to start operating like that, what that does is put the patient first. When you say, hey, pay me $2,000, and in exchange for that $2,000, I'm yours. I don't care if it's 2 o'clock in the morning. You want to snap on WhatsApp. You want to shoot me a picture of something to go look at it. No problem. I'm not dealing with portals and all this kind of stuff. No problem. I'm there for you. You realize that the level of happiness and the reduction in burnout, both for the patient and the provider, is up tremendously. So I would call that a success of a value-based care model.
Arvind, when you did the switch, could you share about your cost-cutting things? What did you have to do in terms of cost-cutting? Because I imagine you didn't need some of the functions you needed before.
Yeah, so I always kept my costs very minimal. I didn't, rent big spaces. I used technology right from the beginning. I mean, my office has been digital since 2002, so we've never had paper charts. I never employed conventional transcribing services. I cleaned my own offices. I only had maybe 2 staff members who did a lot. So my whole principle was based on, if anybody is in the office, they should be taken care of or doing something, touching a patient at some point, whether it's collecting the copay, doing the vitals, showing them how to take insulin, whatever else. I mean, everybody in the office was doing something to help the patient. That was the primary principle. So it never cost me a whole lot to operate the practice. Once I realized that I'm doing a lot of things just to satisfy some third party's criteria in order to get paid, and also realizing that I had no negotiating power to actually say, look, hey, I'm providing a service that's twice as good as everybody else. I said, I don't need this contract. And then I realized, okay, the only solution for me was to walk away from a bad contract. Right? And it didn't serve my patients, it didn't serve me. And I just every 6 months I started dropping an insurance company, until by end of 2008 I had only 2 contracts, and by 2017 I had only 1 contract. So and it worked beautifully because people who stayed with me just knew that I was not going to drop them, and I had no hesitation in seeing somebody for free, even because if they had to be seen. I mean, this was before the days of televisits and all this other stuff, right? So I would, if somebody dropped their bottle of insulin and they needed insulin, I would drive back to the office and have them come in, and I would give them a bottle. And my staff too. So my staff would call and tell them, hey, if you want, you're on my way to home, I can drop off a bottle of insulin for you, or whatever, So we hired a group of people who had the same mindset that we needed to do what's necessary for the patient, period. Nothing before, nothing after. And we decided that how are we going to optimize the time we spend in our office? And actually, funny part was we always operated on a 4.5-day schedule in the office. We never did weekends or overtimes. And yeah, so there were times when, financially we were tight, but because we were operating very efficiently and frugally, we didn't really lose sight of the fact, right? So it would always come back. So there were periods when it was tight, and then it would come back. And honestly, that was what it allowed me to do was capture word of mouth referrals, right? Which were the most powerful referrals to my practice. Because what happened over the period of time, when I started in '99, I had close to 250 primary care physicians referring to me. And by 2018, I had maybe a dozen, because everybody else was acquired by hospitals, and the hospital-based primary care physicians were prohibited from referring to me because I didn't belong to the hospitals. I was an equal opportunity outcast from every hospital system that was around me. Right?
That's a very important point. And actually, I did very, very short research on that. And the number of private physicians is decreasing year over year. And like you said, health systems are buying private practices. And So that means basically, yes, we all agree that there is much more freedom for private practices, private physicians to provide value-based care, the one we were talking about. But the trend is showing that there are less and less private practices. That
Yeah.
means, to my first question, basically the topic of our conversation, and Mendel, you said it correctly. It's very hard to scale this, like on the high level, and that's why there are not that many success stories on like with many patients that provide value-based care.
I
So
said that too.
so the question is it unrealistic utopia in this country? Are we gonna just keep value-based care for smaller practices and it will never go to actual health systems because incentives are not there? And we talked a lot about this. Would you agree with the statement?
It goes back to my risk point. It's not an easy path for many people, for many, especially young physicians. So you have to have this entrepreneurial mind.
So unrealistic utopia is your
No,
is your
I think you're looking at the wrong
Well, look at
segment of
Arvin's story. I mean, he clearly has a success story. So
but yeah, that's what I'm
because
saying.
health systems are designed. So it's like you're asking the prison system to be empty of prisoners. Right?
that'd be
They
nice.
will lose, especially private prison facilities. You're looking at the wrong segment. The value is somewhere else, not in the health system segment. That's why the
But
size in healthcare, the size is inversely proportional to value in health system, in medicine. And that's just about the larger the size, the less value service they provide to the patients.
you're right, but the majority of Americans are using the services of larger health systems.
Because they have no choice.
Right. So that's my question. If we're talking about value-based care adoption across the country, it remains unrealistic utopia because most of the Americans who use services of bigger health systems, they will never get to the point of receiving that value-based care. Correct?
Correct.
Sally, what do you think?
I think it's more difficult in the US than just about everywhere else in the world. And everywhere else in the world hasn't cracked it either. I think there's more examples. In a way, for me, value-based healthcare has become a philosophical pursuit. What is healthcare? What's it for? What are we willing to pay for healthcare as a nation? What's the ceiling? Is the sky the limit? As we develop new technologies, new treatments, there's growing needs in our population. What's the ceiling? Do we care about equity? I'm not allowed to say that word, am I, anymore in the US?
No, 2025.
Yeah.
Over.
Oh, you might have to just erase that one. Sorry about that.
We're gonna edit that out.
Yeah, you better have. So then it comes down to really basic principles. How do we, certainly in my life as a physician, I went into this because I cared about patients. I know that sounds, to a lot of people quite cheesy now, but I cared about my patients. I wanted them to have a relationship with me, that we had a compact between us that was trusting, that meant that I didn't get burned out. My patients had really good outcomes. And somehow we need to marry that up with a sustainable healthcare system where the costs don't become so high that we start excluding people from care or bits of their care, or we're doing bunches of stuff that's frankly really low value, like your great example, Alex, about, you're frankly ridiculous. In my world, that's just a ridiculous waste of your time and money for the system at a grander scale. So this has become about a philosophy for me rather than a rule book and a recipe, and is it or is it not possible in any given system. The principles of it have people in every system with the mindset to do it, as we've heard beautifully from Arvin. But the question is, how do we grow that, and how do we then change that into systemic shift in behavior? And that's true everywhere, not just in the US. But I have to say, in the US, there are a particularly difficult set of hurdles to overcome. So I'm a little bit more optimistic for certain other places, and I hope the US can come on board with some of that. Honestly,
Mendel, you please let's end this pod with your optimism. Give us some good thoughts, and yeah,
So
tell us what you think.
I sat here thinking and, really listening to Sally and listening to Arvin and on the one hand, I love your perspective, kind of comparing it to the prison system where success doesn't mean necessarily no more prisoners in the prison system, but it does mean fewer things being broken about it per se. I fully appreciate the complexities. There's some other core complexities that we haven't even addressed. Actually, the first thing that you said, Arvid, was arguing with my water cooler analogy and talking about how it's very simple. There's essentially a buyer and a seller, and that's it. And recently I really started exploring that on the Healthcare Trailblazers podcast. We just had someone on this week, and it all of a sudden hit me. I don't know why this never hit me before, but all of a sudden hit me. I'm like, oh my goodness. I'm like, healthcare is kind of like you. Okay, and the whole premise of this was that there's a problem by the fact that we look at healthcare as essentially pre-Medicare and post-Medicare is kind of how the country is split up. So you've got Medicare folks, and then you've got basically everyone else. And the problem with that is that you look at patients, and then so that's basically number. Oh, and the second piece of that is I've asked countless doctors, and I'm sure you'd agree with me as well. If you had to choose one decade in a patient's life to take prevention and to take their healthcare seriously, what would it be? And the answer that I get over and over again is their 40s, is the patient's 40s. Because before, in your 20s, 30s, you can pretty much come back from anything except for like really heavy drug use. Past your 40s, so like 50s, 60s, you already pretty much have chronic conditions and there's no coming back from them. You could just manage them better or worse, but that's pretty much it. And if you take things seriously in a patient's 40s, then you can get really serious about diet, exercise, and other habits in their 40s, and you can probably really do a good job. And yes, that's a good. You're saying in the comments depends on family history and gender, sure. But overall, that's the answer that I get from doctors. So my point is, the problem is we don't look at people like that. We look at people as what payer are you? Are you Medicare? Are you Medicaid? Are you commercial? Who are you? What are you paying? What are the programs that I could do for you, et cetera, et cetera. And so all of that basically came where it hit me in the head, where it's like, oh my goodness, healthcare is kind of like, imagine you bought a piece of real estate that I want you to insure, but the real estate gets to decide who owns it. So you go and you buy a piece of real estate, but every year the real estate decides that someone else could own it. And then I come to you and I say, I want you to put a bunch of money into the plumbing, the roofing, and the foundation. And you're like, well, next year the real estate might decide that Alex owns it and not me. So why would I put all that money into it? And that's really how it is. It's like, if we were able to know for sure that we're taking care of this patient for forever, then we could align incentives over, multi-decade long process. But because of the way that it is from the payer perspective, which going back to what you had mentioned at the beginning, anyway, my long story short is that I fully appreciate all the complexity because there's this beautiful intersection between AI and value-based care that both, when married appropriately, I think that if you really get down to it, the fundamentals of value-based care are obviously correct. And this is not necessarily going to account for everything, but a lot of the complexity and a lot of the roadblocks come from the added bureaucracy and the added administrative work and the added kind of workflows that are attached onto already overburdened clinicians because of value-based care. You're part of an ACO, great, that's wonderful. But now you have to do all this reporting and you have to track everything differently. And now you have different spreadsheets and different things, and you got to do everything. And so I think that the administrative burden and the level of automation and augmentation that we'll see with proper use of tools like Gen AI is probably the biggest answer in a fundamental shift as far as alleviating a lot of those burdens and hopefully just leaving the fruit, so to speak, which is better patient care. I really am hopeful that I don't think it's going to be the only answer, but I am hopeful that over these next couple of years we will see a transformation in the burden that I think is just a giant rock that's sitting on top of this hot air balloon that's trying to rise. And so for that reason, I'm optimistic.
I'm pretty sure we can talk for another couple hours easily, but we ran out of time. Something tells me this is not our last episode on value-based care. So thank you so much. Look forward to hear this episode again. And yeah, please subscribe to this channel. Thank you, guys.